On the next section, we'll discuss some of the common pathophysiology seen on the Step 2 exam in terms of the vulva and vagina. One of the diseases that you can see on the Step 2 exam in younger patients is labial fusion, which occurs in the setting of excess androgens, which can either be exogenous or endogenous. One of the common causes of labial fusion is 21-beta hydroxylase deficiency. The treatment in this case is usually conservative at the beginning with gentle separation, estrogen cream, and time. However, reconstructive surgery is an option in refractory cases. Vulvar dermatoses can commonly show up on the Step 2 exam. In this chart, I'm going to review the different epithelial abnormalities, the age group affected, as well as the description of the lesion, which can show up in the Step 2 question stem, as well as treatments of the disease. The first is lichen sclerosus, which can affect women of any age group, but we focus in on postmenopausal women, as there's an increased concern for cancer and this needs to be ruled out. It typically presents with white, thin skin from the labia to the perianal area. It has been termed cigarette paper or parchment paper skin due to how thin it is. The etiology is unknown, however, it responds to steroids and suggests an inflammatory process. Histologic evaluation and confirmation is important to rule out cancer and ensure specific therapy. Lichen sclerosus in and of itself does not significantly increase a patient's risk for cancer. However, age is an independent risk factor in this group, and a biopsy must be obtained in order to rule it out. The next group is squamous cell hyperplasia, also known as lichen simplex chronicus. It can affect women of any age, and typically will present in women who have had chronic vulvar itching. It's been described as the itch that rashes, and patients have chronic irritation and develop hyperkeratosis, which are white raised lesions. The treatment involves removing the irritant, sitz bath, and lubricant in order to relieve the itching. The last vulvar dermatose that we'll talk about in this group is lichen planus, which typically will present in the 30s to 60s and is described using the 4 Ps: pruritic, polygonal, papular, and purple. This also is treated with topical steroids. Next, we'll move on to pathology related to the Bartholin's gland. The Bartholin's gland is located on the lateral sides of the vulva at about 5 and 7 o'clock. It functions to secrete mucus and lubricate the vaginal canal. A Bartholin's gland cyst, or particularly abscess, is a common presentation in the emergency department, as it presents with pain and tenderness as well as dyspareunia. Edema and inflammation are found on physical exam, and there can be a deep fluctuant mass, which can again be tender if it's an abscess. Here we have different anatomic landmarks while looking at the vulva. The clitoris is at the apex. The labia minora are just inside of the labia majora. The urethra and Skene's glands are at the top of the vagina, and the Bartholin's glands are down at the 7 o'clock position. Treatment of a Bartholin's abscess involves simple incision and drainage, or may include placement of a word catheter, which is a small rubber catheter with an inflatable balloon tip inserted in the incision after the contents have been drained to allow for epithelialization of the surrounding tissue so that the tract can be formed and can continue to drain the Bartholin cyst after the catheter is removed. If a recurrence happens, marsupialization, or a special form of incision and drainage where the space is left open with sutures, can be performed. If it still recurs, excision can be undertaken. If a Bartholin's gland cysts arise in a woman who's over 40 years of age, an excision should be the treatment of choice due to concern for carcinoma in the Bartholin's gland. During any incision and drainage, fluid release should be sent for cultures and sexually transmitted infection screening for gonorrhea and chlamydia. I'm going to move on to the topic of vaginitis, and we'll start with a case presentation. We have a 19-year-old who presents with vaginal itching and discharge, and a wet mount is performed showing modal flagellates. We're asked what the most likely diagnosis is, and based on her wet mount, we correctly diagnosed Trichomonas vaginalis. This typically presents with a profuse green and frothy discharge. Gonorrhea and chlamydia are typically diagnosed via culture or DNA probe. On wet mount, bacterial vaginosis is going to show clue cells, and candidiasis will show hyphae. Vaginitis is a spectrum of conditions that causes vaginal symptoms such as itching, burning, irritation, or abnormal discharge. Risk factors involve antibiotic use, which can kill off the normal lactobacillus that live in the vagina and normally keeps the vagina at a pH somewhere between 3.5 and 4.7. Diabetes is a risk factor, as well as an overgrowth of normal flora. Because vaginitis commonly presents on the Step 2 exam, I find it helpful to review the three major causes side by side, reviewing the pathogen, symptoms, diagnostic test, and treatment. Bacterial vaginosis is caused by Gardnerella and presents with vaginal discharge having a fishy odor that is gray to white in appearance. On saline prep, we see the pathognomonic clue cells, and if they're present, the patient can be treated with metronidazole or clindamycin. Candidiasis is caused by Candida albicans and presents with a white cottage cheese-like vaginal discharge. We use potassium hydroxide in order to lyse the squamous cells to make the pseudohyphae more readily apparent under the microscope. If the diagnosis is in question, a vaginal culture can also be performed. Treatment involves miconazole or clotrimazole, or one of the other antifungals. Trichomonas, which is the most commonly caused non-viral sexually transmitted infection, is caused by Trichomonas vaginalis. It presents, as in our case, with profuse green, frothy vaginal discharge. On saline prep, we'll see motile flagellates. Treatment is with metronidazole, and it's important to treat both the patient and her partner. Again, to reiterate, as this may show up as a Step 2 question, if you have trichomonas, the partner needs to be treated as well as the patient you are diagnosing. We'll review on the next couple of slides the different things that we'll see on the saline wet mount as well as the KOH. Here, we have the classic sign of bacterial vaginosis in the form of clue cells. Here we have candidiasis diagnosed on a pap smear. You'll note that the squamous cells are still intact. When this is diagnosed in the office under the microscope, KOH can be applied to lyse the squamous cells in order to make the pseudohyphae easier to see. Trichomonas can be a difficult diagnosis to make, and this is one made on a pap smear. We have an enlargement of the organisms on the right-hand side. We'll conclude our discussion of vulvar disorders by talking about some of the malignant lesions that can be seen. The first is Paget's disease, which is an intraepithelial neoplasia, most commonly seen in postmenopausal Caucasian women. Paget's disease presents with vulvar soreness and itching. It appears as a red lesion with superficial white coating. When Paget's disease of the vulva is biopsied, it is very similar to that of breast lesions, with large pale cells of apocrine origin below the surface of the epithelium. As with all vulvar diseases, a biopsy is mandatory for definitive diagnosis. Once the diagnosis is made, treatment can involve a wide local excision or vulvectomy, depending on the extent of disease. A radical excision is not necessary, but a 2 cm margin is preferred. Greater depth of invasion and lymphovascular involvement are poor prognostic factors. It's important to remember with these patients that Paget's disease of the vulva carries a higher incidence of other underlying internal carcinomas, such as colon or breasts, and these need to be screened for. Squamous cell carcinoma is the most common type of vulvar cancer, accounting for about 90% of the cases. The next most common is melanoma, followed by various types of sarcoma. It presents with pruritus, bloody vaginal discharge, and postmenopausal bleeding, and on physical exam can range from small ulcerated lesions to large verrucous cauliflower-like lesions. I can't drive this home enough when it comes to vulvar disease. A biopsy is essential for all of these diagnoses. After a biopsy confirms the diagnosis, staging is done surgically. Stage 0 is carcinoma in situ. Stage 1, limited to the vaginal wall and less than 2 centimeters. Stage 2, limited to the vulva or perineum and greater than 2 centimeters, with the key being that lesions greater than 2 centimeters have a higher chance of nodal metastasis. Stage 3 is spread to the urethra or anus with unilateral lymph nodes. Stage 4 is invasion into the bladder, rectum, or bilateral lymph nodes, whereas 4A involves distant metastasis. Treatment depends on the disease. If unilateral, a modified radical vulvectomy can be performed, whereas if it's bilateral, a radical vulvectomy must be performed. If lymph nodes are involved, they must undergo lymphadenectomy, and at times concomitant chemo or radiation therapy can be used.